great, thank you. So we'll start with our first case. Let's see if I can load up the slides here. So this was a lady that was actually seen for the first time in our cardio-oncology clinic this week, a 53-year-old female breast cancer patient who was diagnosed with a PT3 or 8.2 centimeter invasive ductal carcinoma. 5 out of 6 lymph nodes were positive on the sentinel biopsy. So she is post-mastectomy and sentinel lymph node biopsy, and her tumor markers returned as ER/PR negative, HER2 negative, or a triple negative disease. And fortunately, all of her staging investigations were also negative. So she has no significant past medical history of coronary artery disease or cardiac disease, including hypertension or diabetes. She's had a few previous surgeries, including a tonsillectomy and a hysterectomy. And her only other significant history is for depression, and she's currently on medication to help manage that. She's an ex-smoker, having quit in 1981 with an approximate 5-pack-year history, and she drinks about 3 glasses of wine per week, and she works as an administrative assistant. Her only medication is desvenlafaxine, or Prestique is the brand name, and she's on some vitamins and herbal supplements. So prior to her consultation, she had a MUGA scan at a peripheral hospital. So unfortunately, we don't have the imaging, we just have the report, but it was reported as essentially normal with an EF of 65%. So we'll stop there and just ask anyone if they have any concerns or questions about the case so far.
I just want to add in, from a medical oncology perspective, this particular woman has very high-risk breast cancer, given the number of lymph nodes involved, and also the fact that all of her receptors are negative, so-called triple-negative breast cancer. So by today's standards, it's one of the more aggressive types of breast cancer, and certainly systemic chemotherapy, fairly aggressive chemotherapy, would be what we would want to do from a medical oncologist perspective. So any concerns so far from the attendees online? Although I understand many of you may be cardiologists and not oncologists.
Any questions from anyone?
Not really. It's Alex Lan here from London. I think from a cardiac perspective, I didn't hear whether she had any symptoms that could be cardiac, any exertional limitation, but otherwise she's not got any overt concerns unless you felt the drug, the desvenlafaxine, had any risk associated with it, but I'm not aware of that.
So we're not aware of that either, and that's a very good question about exertional symptoms. She had absolutely no cardiac symptoms on her initial consultation with the medical oncology team, but that's a very good point. So the cancer treatment plan for her was to administer adjuvant chemotherapy with curative intent, and the regimen that was recommended was what we call dose-dense ACT, or dose-dense cyclophosphamide, followed by dose-dense.
Please mute. If you haven't muted yourself, please mute.
So this regimen is administered over 16 weeks. The first 8 weeks are doxorubicin and cyclophosphamide, which is given once every 2 weeks for 4 cycles, followed by paclitaxel, given once every 2 weeks for 4 cycles. And this is all given with growth factor support. So this patient's first cycle of chemotherapy, which was the doxorubicin and cyclophosphamide, was given on December 9th of last month. That was uneventful. However, a few days later, she developed symptoms of central chest pain and pressure, which did not resolve. She had no cough, no palpitations, no shortness of breath, or no fever or other constitutional symptoms with this pain and pressure. And she waited it out at home for a few days, but finally presented to an emergency department at a peripheral hospital on December the 15th, 2013. So we'll open it up again, whether you feel that there are any specific concerns with her symptomatology at this point.
So it's Alex Clark from London. I mean, obviously the question is whether she's got some form of acute doxorubicin cardiotoxicity or whether she had occult coronary disease that's been destabilized. I think a risk factor profile wouldn't put her at high risk of coronary, but I'd be wanting at least to see what her ECG and some biomarkers are, just as an exclusion for any direct acute myocardial toxicity.
Yes, that's great. That's a very good point. So on physical exam, she actually appeared comfortable. She was on room air. She had no cyanosis. Her vital signs were stable. Her heart rate was 87 and regular. Her respiratory rate was 14. Blood pressure was within the normal range, 123/69. She was afebrile, and she was satting 100% on room air. Her cardiovascular exam was also unremarkable. She had normal heart sounds with no extra heart sounds or murmurs. There were no pericardial friction rubs appreciated. She had normal peripheral pulses, and her JVP was flat. And the remainder of her physical examination was within normal limits. On her initial chemistry, she had normal lights. However, sorry, excuse me? Oh, sorry. So she had a normal lights. However, she did have a significantly decreased white cell count despite administration of GCSF. She was also slightly anemic with a hemoglobin of 105. And her CK was slightly elevated at 230, and she had a rise in her troponin I up to 3.356. Now, I apologize for the quality of this ECG. This was the photocopy of the ECG performed at the peripheral hospital. So perhaps we could have one of the cardiologists try to interpret that for us if they can read it and give us an opinion as to what they think.
Sure. Alberto Morales, cardiology fellow over here at Tampa Memorial Hospital. So it looks like sinus rhythm, normal access, borderline left ventricular hypertrophy. It's questionable, and otherwise I don't see too much going on there. Maybe some non-specific ST changes in antilateral leads, but not too bad with some T-wave flattening, V5, V6.
Great, yes, and that was the opinion of the peripheral hospital as well. Unfortunately, I cut off the intervals, but they were all normal as well. So she also had an echocardiogram. Unfortunately, we don't have the imaging, but we have the report, and they reported normal right ventricular and left ventricular wall motion, as well as no valvular abnormalities, no evidence of pericardial effusion, no evidence of pulmonary hypertension. And they reported a normal left ventricular ejection fraction, but they did not provide a number for us. So at this point, we'll just open it up to the group and see what you guys think the provisional diagnosis may be, and then from then what your initial treatment plan might consist of.
So I'd like to make a comment on the echo, which is both in my experience and also looking at that's a very basic level of report. So what I'd be focusing on if I was seeing this patient would be their diastolic parameters, particularly on tissue Doppler, transmitral Doppler. If you're fortunate enough to have had a baseline pre-treatment echo rather than MUGA, then you've got the ability to compare a pre versus post if you had the echo as your baseline. But obviously here you don't have that opportunity, but I would certainly be interested to look at what her more sensitive markers of dysfunction, because in my experience acute anthracycline toxicity very rarely drops the EF after a single dose in someone previously well, whereas you can see some objective markers on more subtle abnormalities to give you the confidence to say this is myocardial toxicity. But the other sort of thing to make sure she's not having pulmonary emboli, of course, with a troponin rise and some chest pain.
Mm-hmm. Very, very good point, and you're absolutely right. Our hands were a bit tied with the data that we had received from the peripheral hospital. We'll just move on here. We do have trending, though, of her Troponin I levels at the peripheral hospital from the 15th of December to the 19th, and we can see a steady rise over a 4-day period with a slight drop on the 19th. But I think one of the main points here is that she had ongoing symptoms, ongoing central chest pain and chest pressure, which was not relieved with medical management. And at this facility, she was receiving IV nitroglycerin, and just not really improving. So, bearing that in mind, what would people do next?
Yeah, so this is Joe Carver, ongoing chest pain and rising troponin I would catheter.
Okay, great, and that's exactly what happened. So she was transferred to.
Can I make a comment?
Yeah, sure.
I would say I agree. She must have an angiogram, but actually that persistently elevated troponin is one would classically see with an acute coronary syndrome in that dynamic. So I think I'd be cathing her because we should, but with the still view that I'm expecting to find normal coronaries.
Okay, great. So she was actually transferred to one of our tertiary cardiac institutes on December 19th, and she underwent a coronary angiogram on the 20th of December. And just as predicted, she had normal coronary arteries with absolutely no evidence of coronary artery disease. She also had a left ventriculogram during that procedure, and the estimated ejection fraction was 60%. And very, very interestingly, that day, the patient's symptoms fully resolved. She had a post-discharge echocardiogram, and again, I apologize, I don't have the imaging or a lot of the specifics, but it was essentially normal, and there was no pericardial effusion, and her ejection fraction was similar to the ventriculogram at 62%. So this comes to the end of our first case, and we have a few clinical questions that we felt were very pertinent. And the first major question, bearing in mind that this lady has very aggressive disease with a very high risk of disease recurrence systemically, whether or not the group would re-challenge her with an anthracycline and cyclophosphamide, and if so, would they also consider adding in cardioprotection? So we'll open that question up to the group. We'd be very interested in your opinion.
I have a question.
Sure.
Did she complete the first course of chemotherapy, or was she still receiving the doxorubicin while she developed these symptoms?
So both of these medications, the doxorubicin and the cyclophosphamide, are given as a bolus. So she had one dose of each of these drugs just once, and that was about 6 days prior, or 4 days prior to the onset of her symptoms.
Thank you.
So my clinical view is that she should have cardioprotection with, probably in this case, I would advocate both ACE inhibitor and beta blocker, trying to get her to some reasonable dose. I wouldn't say we're going for targets of high doses, and then a assessment prior to her second dose of doxorubicin and cyclophosphamide with close cardiac monitoring and troponin measurements afterwards, and because she's really a signal that she's at high risk of sensitivity, but she hasn't met any criteria to say that we should be stopping that versus the potential risk to recurrence of a malignancy.
Okay. So you had mentioned a beta blocker and an ACE inhibitor. Would anyone consider something like a chelator, like desrazoxane? Okay. So so that's right. So that's a very good point. She actually went on. She was seen by the clinic at our institute, and it was decided not to re-challenge her with doxorubicin. The other concern with her was that she dropped her white count significantly despite growth factor support, and the theory in this patient may be that she is a poor metabolizer of doxorubicin or cyclophosphamide, and so they were quite hesitant to consider re-challenging. So she went on to the paclitaxel component of her dose-dense chemotherapy. But that's a very good point, and we'll certainly bring that up with our group that it may not be necessary to discontinue that portion of chemo. Now, another question that came up is whether or not you would recommend any further.
Could I ask a question?
Sure.
Could I ask a question then as a cardiologist to you as the oncologists? If you think
Sure.
she might be a poor metabolizer of doxorubicin, is there a algorithm for lowering the dose delivered?
Hi, it's Susan speaking. So it's not my particular patient, but absolutely. I mean, usually, or when we suspect any toxicity from doxorubicin, one of the approaches is you can potentially re-challenge, right, with a lower dose. Now, in terms of there being algorithms per se, I don't think there are any standardized algorithms, but we certainly do use that approaches when patients experience other anthracycline-related toxicities, whether they be, severe nausea and so on. So that definitely would be an option in this particular case. I think perhaps the treating oncologist may have been worried about the significant myelosuppression, but again, another avenue would have been to dose reduce and sort of observe closely. So it definitely would be an option.
Susan, is there any consideration about doing this in hospital and doing a prolonged infusion? We're switching to something like Doxil.
Yeah, so we haven't, so you mean the sort of 96-hour doxorubicin infusion, we typically have not done that in the breast cancer population for a long time, although I recognize that that tends to be better tolerated. But so could we do it? Yes, we could. It's not something that we tend to do very often. Whether that would have made it easier or place her at a lower risk of this event, I think is really up in the air. I wouldn't know unless we tried it. I don't know of any data to suggest that the longer infusion of doxorubicin would particularly protect someone from experiencing this type of side effect. And if there's other people on the line who know of data pertaining to that, but again, I think these are all reasonable options.
And so, so I think our provisional diagnosis that the group consensus came to is that this was an acute anthracycline toxicity. So just one question to leave out there is whether or not there may be a genetic predisposition to this condition in the population. We're not aware of any data on that, but that's a very interesting question.
I have a question. Was a cardiac MRI done during that hospitalization? I think with T2 weighted imaging, we could have got a lot of information to the cause. I think it's clear cut. It sounds like she had cardiotoxicity, chemotherapy-induced myocarditis. T2 weighted imaging would have shown the acute inflammatory and edematous stage, as well as late gadolinium enhancement, proving the diagnosis at that time. But was any thought of cardiac MRI imaging proposed at that time?
That's a very good point. I'm not aware. We certainly have that capability here, but I think it's hard for me to say because I wasn't directly involved in this patient's care, and we saw her in our cardiac oncology clinic about 2 or 3 weeks after this resolved. So the clinical decision making at our Heart Institute, I'm not totally aware of, but that's a very good point.
We can certainly follow up on that to see if she had that done. They do have cardiac MRI at the Heart Institute, but I agree with you. I think that in these particular cases, which aren't that common, that would be really valuable information which would help us in terms of clinical decision making. We can relay that back to our Heart Institute if it wasn't done.
So, so as we said, we feel that this was an acute anthracycline cardiotoxicity event. And just a quick literature review, there's really not a lot of data on this condition. It is quite rare. But she certainly fits the clinical picture. She had symptoms that occurred within days of administration. And her symptoms resembled a myocarditis with the elevated troponin and the chest pain. And also typically symptoms resolve spontaneously within a week, and that's exactly what happened with her. She didn't, however, have a lot of changes to her ECG or an LVEF reduction. but she certainly had an elevated troponin I level, which fits with this clinical picture. So if there's not any further comments on this case, we do have one more case that we'd like to go over.
Do y'all? I'm sorry to get in there. Do y'all have the capability of doing strain imaging? That's also very useful to following these patients, assessing early cardiotoxicity during actual chemotherapy, induction, and maintenance, and all that.
So we actually do, and so that's something that we will actually bring back to the group as well, whether this patient would have benefited at the time or whether she'd benefit with ongoing chemotherapy. Thank you for that comment.
I have a quick question too. Do we have any idea how often these transient changes might be? For instance, we have quite a few echoes here that just incidentally show a decrease in EF several days after initially receiving various types of chemotherapy agents.
That's a good question. I'm not aware. Is there any other cardiologists there that might be able to answer that?
So
I'm not aware of any data. I don't think it's been systematically evaluated to my...
I think that would certainly be some interesting data to capture, and that's something that would be a reasonable project.
I also, Jerry Walker here, I also have a question. As an oncologist, do you feel comfortable, you know, now that one of the other cardiologists on the panel here has suggested preemptive treatment with classic heart failure medications, do you feel comfortable pursuing further chemotherapy as long as we maintain the ejection fraction?
So I think the answer to that question is yes. We have certainly a large patient population with delayed cardiotoxicity, both with an anthracycline or other medications such as trastuzumab. And those patients are managed medically with drugs such as beta blockers and ACE inhibitors so long as their ejection fraction is maintained. The issue with anthracyclines is that the administration of these drugs occurs over a very short period of time. So a lot of the effects of these medications are that we pick up on them much later. So it's not common for us to see acute drops in ejection fraction during a course of anthracycline chemo. Most of these drugs are in and out within 1 to 2 months.
What?
It's interesting.
Oh, go ahead.
I think from a medical oncology perspective, when we see cases like this, it would be nice for us to have a better understanding of which patients are at risk and which patients need to be perhaps followed more closely and or have preventative measures instituted prior to initiation of their chemotherapy. And so, you know, I think we have a better understanding of delayed anthracycline cardiotoxicity, but we do not have a good understanding at this point of those patients who are going to run into problems more acutely, and I think that would be a very interesting area to study further. And then yes, those patients could be prophylaxed, per se, with medications to try and prevent any toxicities.
And that's I think what I was getting at is I think it was Daniela Cardinale out of Milan was you know, one of the folks that was showing that predictive capability of elevated troponins for determining who would develop left ventricular dysfunction. And now with the recent results of the Overcome trial and some of these other studies in the last couple of years, it seems that we're starting to preemptively treat, or you know, preventive medicine, I guess, using these agents. And I'm wondering if other cardiologists here in the panel are actually aggressively using these medications to try to prevent LV dysfunction.
So Alex Lyon here from the Brompton in London. So I am, if the patients I think have a high pre-treatment cardiac risk, But in this sort of lady who didn't have any overt risk factors, I think it was only now that you have a signal that she's sensitive that if you want to support the optimal oncology care, I then go in aggressively. And in a way, she's got quite objective things, chest pain and troponin rise, and a reasonable troponin rise in the amplitude, although depending on the assay. What's more subtle is the patients who have mild sinus tachycardias, but troponin negative. But so new changes that are probably new subtle changes on their diastolic physiology on echocardiography. So you think that there's probably some mild toxicity, and should we be treating that, or do we need, how many of these more sensitive markers need to be abnormal before you introduce a preventative strategy? And obviously those are a lot of unanswered questions. But I think as I said before, once you've got troponin rise, and certainly with symptoms, and I expect her diastolic physiology was abnormal, and if you put her in an MRI scan, acutely she may have had some T2 signal, that would be perfect evidence for me to give a dual cardioprotective strategy.
Are you using the iron chelators as well?
No, personally in London and the UK, no. The other thought I had, as well as the sort of ACE inhibitor beta blocker approach, would be liposomal doxorubicin and what the oncologists felt about that.
Okay, thank you.
You know, it's interesting, the uptake of liposomal doxorubicin in the breast cancer population has not been high. In Canada, there's a funding issue, unfortunately, for breast cancer patients. It's used more in the ovarian cancer population, and then I guess recently there's been a shortage, was my understanding, of liposomal doxorubicin. So it is out there, but at least I'd be interested in hearing from the U.S. if anyone is aware of it being used that aggressively. But in Canada, it's not been funded for breast cancer patients. Comments? We'll go to the second case. We have a second case. It's shorter, but I think it's interesting.
So this is a case that is ongoing. This is a 48-year-old female who initially presented to a peripheral emergency department with acute hypertension, and at that time a left breast mass was discovered. She went on to be diagnosed with a left-sided inflammatory breast cancer with axillary lymph node involvement, and the tumor markers on the sample were ER positive, PR positive, HER2 negative. Now she's got a significant history of Marfan syndrome with left subclavian and left internal mammary artery aneurysms. She's had an embolization of the left internal mammary artery, as well as a stent in the left subclavian artery in October of 2011. And this unfortunately was complicated by a procedural type B dissection. She also had a type A aortic dissection with aortic valve insufficiency, which was repaired last year. And at this time, she has a large descending thoracic aortic aneurysm measuring over 7 centimeters. Surgery had been recommended and was planned, but at this time it was deferred due to her recent breast cancer diagnosis. As you may be aware, inflammatory breast cancer is quite aggressive and needs to be treated quite promptly. She did have a pre-treatment MUGA scan with an ejection fraction of 62%. Now, she has some pertinent social history. She's self-employed. She's not a smoker. She's not a drinker, but she is a Jehovah's Witness, and so blood transfusions are not an option in this patient. Her current medications include clopidogrel, amlodipine, metoprolol, Ventolin, and rabeprazole. And her blood pressure prior to treatment was well controlled. This is just a quick screenshot of her most recent CT thorax showing the large thoracic aneurysm. And just a sagittal view there showing again the large aneurysm. So her breast cancer treatment plan was neoadjuvant FEC-D. So what we mean by neoadjuvant is chemotherapy prior to surgery. And the FEC-D regimen includes 3 cycles of a 3-drug regimen, which includes 5-fluorouracil, an anthracycline named epirubicin, as well as cyclophosphamide administered once every 3 weeks, followed by 3 cycles of docetaxel once every 3 weeks. And then if she had response to this, the subsequent plan would be surgery plus or minus radiation, and then long-term endocrine therapy. So at this point, does anyone have any concerns about her chemotherapy treatment plan?
Yeah, this is Harrison in Tampa. I was going to ask you about whether you would use an ARB in her because of the Marfans and the work by Hal Dietz on the children and on the mice with the problem with the TGF beta 1 and the necessity of blocking that. And apparently there's some information the children and perhaps the adults, I'm not sure. Certainly the mice work was very elegant.
That's very interesting. I'm not sure what the clinical reasoning was in this patient not to include that in her medication, but that's a very good point. So
what was her baseline? What was her baseline hemoglobin prior to starting chemotherapy? Being that she's Jehovah's Witness and she's about to embark in this chemotherapy, bone suppression, and she has a descending thoracic dissection, aneurysm as well. I'm very concerned, obviously, with ongoing treatments in her. She's going to be high risk regardless. But if we drop her hemoglobin and she has some indication for surgery, this may be a very significant concern at this point.
From my understanding, her hemoglobin was within the normal range. So that was reassuring. But you're absolutely right. She would be at high risk of anemia related to her chemotherapy and all of the subsequent complications from that. The other issue as well that the medical oncologists were concerned about were abrupt changes in her blood pressure, especially related to symptoms such as nausea and vomiting. And I think that was one of the main issues that brought her to the attention of the cardio-oncology team, was to appropriately manage this patient's blood pressure throughout chemotherapy. So she in fact did develop some significant nausea and vomiting during her first cycle of chemotherapy, and her antiemetics were modified. She was actually on a clinical trial looking at the intensification of antiemetics during treatment. And so after the first cycle, fortunately, this patient's nausea was much better controlled. And her blood pressure as well was well controlled throughout her chemotherapy. The target blood pressure that was set for her was a systolic less than 120. And the patient was able to get through all 6 cycles of her treatment and responded, and then went on to have a bilateral mastectomy last summer. So just to review the pathology, she had a residual lobular carcinoma, pleomorphic subtype of an intermediate grade. She had clear margins, but she had 3 out of 7 axillary lymph nodes positive, and her tumor markers remained the same: ER positive, PR positive, HER2 negative. So this was an interesting question that arose, is whether there would be concerns regarding the timing of her adjuvant chest wall and axillary radiation with her surgery that she requires for repair of her aortic aneurysm, and what the optimal sequence of treatment would be in this situation. So we'll open that question up to the group to see what people think. I'm not sure if there are any radiation oncologists in the crowd today. Perhaps not. So there was. So there was some concern that perhaps giving radiation prior to surgery may make a subsequent surgery more difficult in freshly irradiated tissue. So the the decision between the radiation oncology team and the cardiac surgeons were to proceed with her aortic repair first. So that's what was being planned, and she's about to have that actually this month. Now, the other question was what would be the optimal procedure in this patient, keeping in mind the patient's inability to have a blood transfusion. So two surgical options were presented to the patient, and we're not aware of what option was ultimately chosen, but we suspect that it was option number 2, which was considered to be slightly less risky from a transfusion point of view, but a little more unusual from an aortic aneurysm repair point of view.
Yeah, let me ask you, is this an experienced team with Marfan's syndrome? There are people that specialize and have Marfan's clinics, like the Duke Cameron is a thoracic surgeon at Johns Hopkins whose specialty is Marfan.
That's a good question. I'm not aware. However, reading the patient's chart, it seemed like the surgical team was comfortable managing this patient surgically. But that's a very good point. Especially in a situation where there are some higher risk factors, including the inability to provide blood transfusions. So another question that has come up, we're not quite there yet with her, but what the optimal choice of adjuvant hormonal therapy would be in this patient, and specifically whether there would be concerns for the administration of tamoxifen. So we're not sure if there's any medical oncologists in the group today and whether they'd have a strong opinion on that.
In terms of thromboembolic risk?
Yeah.
So would people be concerned, given all of her cardiac history, about the potential thromboembolic risk associated with the use of tamoxifen in this case? From a cardiology perspective, would there be any concerns?
I was thinking that there's really not association with Marfan's and thromboembolic disease unless it's the thrombosis that occurs in the dissection. And so probably not.
Okay. So in this particular patient, she's in her early 40s. The first choice for endocrine therapy would be tamoxifen. Now, the treating team decided that they were uncomfortable with the procoagulant effect of tamoxifen, even if only slight in this patient. So they decided against tamoxifen and instead preferred to administer an aromatase inhibitor, which is normally used in postmenopausal women. And so the plan was to provide ovarian ablation. Now, I think typically, I think ovarian ablation would be completed with a laparoscopic oophorectomy. However, in this patient, it was decided to proceed with radiation of the ovaries, which is a little bit unusual this day and age, but it's certainly reasonable. And she would have that done at the time of her chest wall radiation. And then once that was completed, they would initiate use of an aromatase inhibitor long term.
So I was asking,
yeah, sorry?
I'm going to ask you about whether you're contemplating abdominal aortic aneurysm stenting, or what the procedure is anticipated for the abdominal aorta at this time.
That's a good question. I'm not aware of that. There was certainly nothing in the last clinic note about that. I think it was almost exclusively targeting the thoracic aneurysm. But that's certainly a good point, because she's very likely to require further surgery in the future. Anyway, this was just a very quick case, just to highlight some of the breadth of patient issues that we see at our cardiac oncology clinic.
The other thing I wanted to raise was that from this case is also presented at our breast cancer tumor board, and actually many of the medical oncologists were very concerned about treating this individual with chemotherapy, and I think some of that stems from the lack of comfort of dealing with patients that have other significant issues, in this case cardiac issues. And so we then obviously we presented this case at our cardiac oncology rounds, and really learned a great deal from our cardiologist in terms of, yes, she could proceed with her chemotherapy, and they could manage the hypertension and the cardiac issues. So to me, this was a very good example of how we can work together to alleviate some of the discomfort level from the oncologists, and the cardiologists were very helpful in doing that. So I thought it was a very good example of the value of having that interaction between the two disciplines.
That's very good, Susan. We're dealing with a couple cases that our interaction is pretty important with someone who has breast cancer and METs and has a pericardial effusion and is getting pre-tamponade hemodynamics, and then we have someone who is getting a QT interval prolongation potential drug who has atrial fibrillation, is on flecainide. So there seems to be a lot of common ground that we're meeting the oncologists on. Once we get started together with the oncologists, a lot of things seem to come up along the way.
Great. Well, thank you very much. We hope that you found these two clinical cases interesting, and they certainly generated some good discussion. We'll just end by just plugging our 4th Annual Canadian Cardiac Oncology Network Conference, which is coming up this May 8th and 9th here in Ottawa. You're all more than welcome to join us. It's a 2-day meeting, and the contact information is on the bottom right-hand side there. It's our research associate, Nadine Grain.
Thank you very much. Thank you very much for everyone attending. Does anyone have any other comments or questions? I know that there's a lot of interest in having cardio-oncology fellows, and I think Dr. Carver is starting that, and I know you have one, Susan. And we're looking at that for a program too. And if anyone has any information they could send me, this is Eric Harrison. If you have some information, you can email me. We're looking at starting the same program, and we need to submit some stuff to our GME. So if there's no use reinventing the wheel, so if you have some information you could send me that you've used for the induction of your program, that would be very helpful.
Yes, that's very, yes, we'll send you our information. In fact, one of the sessions at our meeting this coming May will be specifically geared towards cardiac oncology fellowship programs and trying to develop, if you will, a common program that would be beneficial for everyone. So that's one of our talks at our upcoming meeting in May.
So that would be a good reason for me to get up there. That sounds good. Let's see, there was...
The snow will be gone by then, I promise.
Thank you. Anytime you would like to have a collaborative effort down here in Tampa and the snow gets a little too deep for you, anyone is welcomed to come in and spend a week with us. We'd have a lot of fun. And the thing we offer cardiac fellows is the cardiac imaging opportunity. And so we have cardiac PET, cardiac CT, and cardiac MR under one roof. And we're engaged, we have a 4th-year fellow, Dr. Morales, and we're engaged in questions in cardiac imaging every day. So we would be delighted to have your fellow rotate down here if someone's interested.
The other thing that just came to my mind as you were speaking was, given that this is a relatively new area and that there are not that many fellows, I think it would be really fantastic if the existing fellows could, perhaps travel to other centers to spend a week there too, and we could share our fellows, and they would really get a broad, experience across different centers. So, in developing some sort of a program for fellows, I think that would be a very valuable experience.
Sounds like a great idea. We welcome anyone down here for cardiac imaging. We have a very active group, and we have some very dynamic dialogue every day on some of our cardiac imaging cases. So thank you everyone for attending, and I look forward to next month. I'm not sure who our presenter is next month, but we do have a list for the calendar for the year, and if anyone wants to volunteer, we'd be delighted to have you. And thanks a lot. We look forward to seeing you, and we're also going to be continuing our dialogue with Dan, developing the best practice model and that's the I guess the last Thursday or the fourth Thursday of the month. The fourth Thursday of the month at the same time. Thank you so much.
Okay, thank you.
Bye-bye.